Good afternoon to all of you. I have modified my talk a little bit. The managing the bone defects, there are various options available, but we routinely use allografts. So I particularly concentrate on the use of allografts in managing the bone defects. So the bone defects can be primary bone defects or secondary bone defects. Primary bone defects, when the bone loss happens at the site of accident or at the time of debridement. Secondary bone loss, when there is an infection, removal of the necrotic segment leading to bone loss is called secondary bone loss. The primary bone defects can be wedge defects when there is a unicortical bone loss is seen, or segmental bone loss like intercalary bone defect is seen like this. So how these kind of major bone defects happen? When the knee is in flexion, the moving object hits the person. The initial impact of the moving object results in the transfer of the energy from the moving object to the limb, and then immediate fracture can cause tear in the supracondylar region, either through the patella or above the patella. And then when the violence continues, there is one another fracture happening at the higher level, and then when the violence continues, the whole bone gets ejected out. Here the wounds sometimes can be smaller, but since the violence is more, multiple level fracture can result in ejection of the fragments and then cause bone loss like this. So whenever we see these kind of major bone defects, intercalary bone defects, it is a huge challenge to anybody. And the common options that are available are either bone transport or free vascularized fibula graft, well documented in the literature. So if you look at the bone transport, it is a versatile method. Any defect can be treated with this. It is useful for metaphyseal, diaphyseal defects. And in addition to the defects, when there is a deformity, it can still help us to correct the rotational deformity. It can go up to 20 centimeters defect also. However, it is quite cumbersome to the patient. Poor patient compliance is noted. It involves multiple surgeries. There is a chance that it can end up in poor results leading to secondary amputation also. Free vascularized fibula graft, it can be used up to 20 centimeters of bone defect. The advantage is that it is a vascularized, viable, autogenous graft which has got a structural strength. The disadvantage being it is a complex surgical procedure. The vascular anastomosis takes quite a long time. There is a risk of chance of failure, and there is a mismatch in sizes compared to the native bone versus the free vascularized fibula, and it needs prolonged protection to prevent further fractures, and sometimes there is a chance that it may not go for union, the infections and cause failures as well. So in the literature also it is mentioned that in the various studies that the treatment of major bone defects like this can be, it is a prolonged treatment, it involves multiple surgeries, financial problems are also seen, there can be a poor functional results leading to secondary amputation. Now the question is whether allografts overcome all these disadvantages of both bone transport as well as free vascularized fibula. The advantage of allograft is that it is a well processed gamma radiated allograft. It is a very safe bone to use, and it reduces the blood loss, easily reproducible procedure with reduced morbidity. The advantage is that they are available in large quantities if you have a bone bank. So the problems of allografts is that we need to have the bone bank where we process them and gamma radiate them and store them, and it is a dead shell of bone. It doesn't have any osteogenic potential. It has only osteoconductive property, and there can be sometimes infections and fractures, graft versus problems as well. So the role of allografts managing these kind of bone defects, it is very well documented in the tumor surgery, but not in open injuries with bone loss like this. So we did a study of open injuries with bone defect for a period of almost 8 years time, and in 21 patients with a long segment bone defects we were used. Among the structural grafts that were used, 21 patients were selected for open injury group, and we can see that the plate fixation was done in majority of them. Only one patient had a nail fixation. The average bone loss is about 10 centimeters. So, 19 patients among the 21 patients went on to heal without any further requirement of procedures, and 2 patients required secondary procedures for to achieve the bone union at the non-union site. We can see that there is a 11 centimeters of bone defect, small wound. This needs, whenever a patient presents like this, there can be a hypotension and multiple injuries possible. So, it needs adequate debridement and external fixator damage control strategy on the day 1, followed by bone defect reconstruction. Here the technique is that we choose the distal femur allograft, which is a processed and then gamma radiated allograft shaped to the defect that you have, and then the intramedullary canal has to be reamed, and then iliac crest grafts, cancellous iliac crest grafts are placed throughout the length of the allograft, and also proximally and distally at the graft host junction. So, this is how it is being used. The allograft is being placed into the defect, and then cancellous grafts are placed into the canal of the allograft, and then plate fixation has been done, and this technique has been reported in American JBJs as well. So, this is how it has been fixed. The advantage is that it immediately fills up the whole defect, and then it gives the structural support, and then we can start early knee joint movements, and then weight bearing also as early as possible. This is at the end of 3 years, we can see that the allograft is incorporated very well. Healing has happened both proximally and distally, and the advantage is that we can, since we are mobilizing the knee joint early, we could get as much as possible. We can see that more than 100 degrees of flexion. So, here it is a single stage procedure compared to the free vascularized fibula or bone transport, where multiple procedures are required. Single stage procedure, anybody can do it if you have a bone bank and have a allograft facility. So, we had the complications in 3 patients, and all of them subsided with one another subsequent procedures. There is no major problems. So, another technique, Capanna technique, it is initially described for tumor reconstruction. We have modified it by using a skin island technique in addition to the free vascularized fibula. Here the allograft gives the structural support, and then free vascularized fibula gives the biology, and then skin island is helpful to monitor the viability of the free vascularized fibula graft. Here you can see a 31 years old gentleman, 16 centimeters of bone defect. The allograft is selected for the length of the defect, and then the free fibula is pegged inside. You have to make a long trough and then peg it inside, so that it does not cause compression of the anastomosis, and then it is been fixed like this. Here it gives immediate structural support, biology is provided by the free fibula, and then stability by the plate fixation, and we can see that at the end of 2 years he has got a quite good range of movements. The skin island also is, we can see that it is viable.
Sir, you have only 2 more minutes.
Yes, sir. So, here we can see that he has got a good range of movements. The advantage is that since it is a single surgical procedure, we could mobilize the knee joint as early as possible, so that we can get a good movements like this. So, apart from this, sometimes we can see in young patients spontaneous bone healing is also possible in these kind of major bone defects. Here is a 23 years old gentleman with 10 centimeters of bone defect. When you maintain the length of the limb with adequate stability, rotation axis is maintained, the periosteum gets stretched to the length. So, small wounds, large bone defects, the periosteum is most of the times is intact, and when you stretch to the length, it normally it throws the bone. Here we can see that at the end of 2 months there is a callus formation, at the end of 9 months there is a complete bridging of the gap, and to prevent refracture we have just stabilized it so that we can mobilize the knee joint also. So, here we can see that he has got reasonably good range of movements. So, to conclude, managing the major bone defects around the distal femur is a major challenge. Primary amputation is most of the times possible. Poor results are possible when you choose for salvage. Selection of the patients is very important, and the allografts can be used up to 15 centimeters of defect. The advantage is that we can mobilize the joint early weight bearing is possible. See, it is a single stage reconstruction, and it is very cost effective compared to multiple procedures. The total cost compared to the single stage procedure, and this is, since being a gamma rated allograft, it is a very safe bone to use. Thank you.